Doctors, we are live now. You can start the session.
Oh, okay. Yeah. Good evening to all. On behalf of Tamil Nadu Ophthalmic Association, I extend a warm welcome to all the panelists, speakers, and moderators, and my dear colleagues, Dr. Nirmal, Dr. Arumadi Varman, Dr. Sriram, Dr. Atik, Madhura Gopal, Dr. Sharmila, and Ravi Shankar, and all the office bearers of TNOA, and our respected past president, Dr. Mohan Rajan. And really, it's a wonderful evening. I very happy that all of you have spare your time to participate in this wonderful webinar on firecracker injuries. Really, it's because Diwali is nearing, so most of us, all of us, come across so many problems due to cracker injury. From starting from minor lid burns to ruptured globe or intraocular foreign body with so many other associated problems. So in that way, so this seminar is, we have organized Diwali. And of course, all of you know TNOA since last 2 months, the new office bearers we have taken in charge from Dr. Mohan Rajan and his team. And we are planning to do so many activities. In that, we have done a few of the activities like guest lecture, and we are planning to have every month, and also master class, and then seminar webinars like this on the eve of eye donation fortnight and World Sight Day, and of course now during Diwali. And something like that we have planned to organize in this whole year. And another important thing I want to say is, we want to have, because last year, because of the corona, we are not able to go into the periphery. The ARC meeting we used to conduct in different two-tier cities, but because of corona, we were not able to. But now we thought we can strengthen the district ophthalmic facilities. Even of course, we can couple. Suppose there is a very minimal number of ophthalmologists, we can couple 2 or 3 districts so that we can form an association, and also to strengthen them and to bring them into the mainstream of TNOA, so that the knowledge, whatever we discussed here or whatever we go into the field, will be useful for them, so that they can give a better care for their patients. So these are some of the various activities that we have planned. So today I'm really happy again that so many stalwarts in the field of anti-segment and post-segment, like Dr. Rao, Asana Madam, and Thuru, and Reddy, my dear friend Reddy, and the speakers like Dr. Naresh, who is a well-known retina. We have taken a mixture of topic, because cracker injury will involve anything. So something on retina, glaucoma, cornea, orbit, something like that. So we have a wonderful speaker today. And at this juncture, I got to thank our Dr. Reveri, who has organized going to moderate the session. And also, she is one who has organized all these topics and everything, coordinating with all the speakers, etc., with Prabhu. And of course, our ARC chairman, Dr. Atik. And of course, Namrata is not able to join, but he sent a video. And also, I have to thank RLM for sponsoring this session, and Numeratech for, as usual, for the IT support. With these few words, I just ask our past president, Mohan Rajan, to say a few words.
Thank you very much, sir. Good evening. Are you able to hear me?
Yes, Mohan Rajan. Yeah.
Yes, sir. Thank you very much. In the introduction of Dr. Ramakrishnan during the TNOA conference in Coimbatore, I mentioned as Basha of TNOA, and he is doing exactly that. And the way he has taken TNOA to a different level altogether is for everybody to see. And the cracker injuries is very close to all of our hearts, and especially Dr. Ramakrishnan has done tremendous work, and his video on, especially in from Aravind Eye Care System, Tirunelveli, on cracker injuries is very educative as well. And last year, I remember very well, we had a TNOA APOT seminar on cracker injuries, and which was very successful. This time also fantastic faculty and very important need of the heart, because it's very important for all of us to prevent these cracker injuries, educate the public, educate the ophthalmologists, educate the physicians and other doctors also about the what you call the complications or implications of the cracker injuries, which are very important. So I wish the webinar all the success. I'm sure it will be because of the wonderful galaxy of faculty we have, both in anterior segment as well as in posterior segment. It's always a pleasure to be in TNOA. And I also, at this juncture, I would say that TNOA is probably doing the best as far as the ocular ophthalmic trauma in this part of the country is concerned. And you can see consistently we are doing a lot of webinars, especially on ophthalmic trauma. And every year and every few months, we have been doing that for the past so many years. And it's one of the very few state associations who has taken this ophthalmic trauma to a different level. And we have to thank all the office bearers of TNOA for this wonderful, opportunity, and also the wonderful teamwork, I would say. The teamwork of TNOA is there for everybody to see. Thank you very much, sir.
Thank you, Dr. Mohan. Nirmal, you were our president-elect.
Thank you, President. And let me at the outset wish all of you, all the office bearers, the speakers and panelists of today's webinar, happy Diwali and safe Diwali to all our people. And so Diwali season always is memorable for me, because ever since I joined post-graduation, I've been always on duty because of my name, and as well as the only person available to do duty. So almost the last 30 years have been looking at cracker injuries from PG days, assistant, and then now running a hospital. So even now I'm on duty this Monday also. So cracker injuries has been very close to my heart. Seen almost all sort of cracker injuries, and been guiding postgraduates and juniors. And now since Dr. Mohan has opened up this activity, I need to inform all of you that on behalf of the Ocular Trauma Society of India, we did along with the All India Ophthalmic Society and APODS, I happen to be the chairman of the advocacy committee. We took up this initiative a few months back, kept writing to the national organization on the standardization as well as preventive aspect of this firecrackers during the Diwali season, as well as elsewhere during the festivities. And the National Human Rights Commission took up this initiative in a big way. We had a meeting at Delhi, and based on the discussions and seeing the huge number of ocular ophthalmic trauma, the National Human Rights Commission has now given advisory to all the central government as well as state government and various ministries about controlling and standardize the crackers. So on the crackers part of it, they have advised standardization on the packaging, and also regulating the sale of certain crackers to only commercial elements and not to the children and adults. So this advisory has gone to the Ministry of Industry and Commerce, and this has been sent to all the manufacturer of crackers as well. There is also a regulation with reference to the import of Chinese crackers. So this again, hopefully in the years to come, this will help in preventing the various injuries that happen with all this imported crackers. So the third aspect is the community activity, because many of the injuries happen to the onlookers and bystanders, because this happens in our roads. To make that make our roads more safer, the advisory has focused on community and only cracker bursting and cracker restricting the timing, I'm sure all of you are aware of the High Court and the Pollution Control Board initiative in Tamil Nadu restricting the timing. So this will again improve the safety norms for this activity, and also restricting certain activity only to open areas and grounds. So this hopefully will come up in the next few years to come. So these are the initiative as an association we done. So I thought it's my duty to inform the members as well as the office bearers about this recent activity. So with all these things, hopefully our festival will be more safer and we'll have less number of debilitating ocular trauma patients. Thank you so much and wish you all the best.
Thank you, Dr. Nral, for updating all this. Thank you very much. Dr. Arul Varman, Vice President. Dr. Arul was there.
Is he there?
Yeah, I saw him.
Yeah.
Okay. Sriram.
Sir, good evening, sir. Good evening, everybody.
Yeah.
Yes, I just want to add one point on what above and overall what's been said already. Probably cracker injury is one part of our things which we see which can be totally prevented. For example, if you're even looking at diabetic retinopathy, whatever you do, you cannot really prevent it totally. But cracker injury is something which is totally unwanted and you can totally prevent it if you just take a very, very basic amount of precaution. So that is why I was very happy when RK sir released that video and that image on prevention of injuries. And we've done our level best to propagate it across non-medical groups as well. So it reaches the public. So this prevention of cracker injuries is also as important as management of cracker injury. With that, With that, I think I'll end this thing and not keep people waiting anymore for the session.
Good. Okay. Thank you all. Thank you. Now I hand over the podium to Dr. Revati, who is moderating the session. Over to Revati. Dr. Revati.
I think Dr. Atik would like to.
Oh, okay. Atik, yes, it's chairman.
Yes.
Okay, yeah.
Heartfelt thanks to our president and Revati madam for having put up a wonderful schedule and a terrific galaxy of speakers. It is an honor and privilege to have two great moderators for today. Revati madam, she is the head of cornea and cataract services at Arvind Eye Care Hospital. She is a pioneer in infectious keratitis and in keratoplasties. She's done quite a lot of work. She's known for her clinical acumen. She's a reviewer in multiple international and national journals. Thank you so much, ma'am, for sparing your time for TNOA. And the young and dynamic Dr. Prabhu Vijayaraghavan. He's the head of cornea and refractive services at Shankara Group of Eye Hospitals, Coimbatore. He's received the ACRS Best Paper Award in 2014, which is a great achievement at that time. Congrats, Dr. Prabhu. I just went through your CV. It was extremely impressive. Thank you so much for sparing your time and being with us. Thank you, madam. Over to you, madam, to take over the session.
Thank you. First of all, I thank TNOA as well as Dr. RK sir for giving this opportunity. And this is to organize this wonderful webinar. Which is a very important one and timely one. And I'm very happy to hear all the main people, the TNOA office bearers, and especially I'm very much happy to hear Dr. Nirmal Frederick's updates about what as an organization we have done to regularize this, because as already mentioned, this is a very important and completely preventable also. And as an association, whatever we have taken, the efforts which are taken, I hope they will be soon. It will be very useful for us, and some effect will be there. And with this, I would like to introduce our panelists, Dr. S. K. Rao. You all know Dr. Srinivas K. Rao, one of the a well-known corneal person is in Darshan Eye Hospital in Chennai, who came from SN previously. And like we would like to hear his immense experience in this. And Dr. J.K. Reddy also doesn't need any introduction, from Sankara Eye Hospital, Coimbatore, and who is well known for his out-of-the-box thinking and solutions. And Dr. Vasantha Madam is one of the doyens in cornea, especially in Tamil Nadu. And we would like to have her as an experienced panelist. And also Dr. Thiruvenkadakrishnan, head of the cornea from Aravind Eye Hospital, Chennai, is also well known for his experience, and we would like to have him as a panelist. And also we like to have Dr. Namrata Sharma as a speaker, though she is not able to directly join because she is overseas. The connectivity problem might be there. So her actually we roped in mainly to find out what AAOS is taking, what steps AAOS is taking in regularizing these firecracker problems. And already we have got very good news from Dr. Elmer Frederick about this through TNOA, whatever TNOA has done. Thank you. Now we'll move on to the introduction of speakers and the topics. Thank you.
This outset, thank you for the opportunity of moderating this wonderful session. And we have an excellent set of speakers. No need to introduce everyone, but still for the customary, like Dr. Anita Venugopal is the Chief of the Department of Cornea and Refractive Services in Aravind Eye Hospital, Tirunelveli. She has 10+ experiences of handling various kinds of ocular injuries, and she will be talking on pathophysiology of the firecracker injuries and various modes by which the ocular injuries happen. Dr. Srinivas K. Rao will be talking on ocular surface burns, and Dr. Menaksha, who is a chief in the Department of Orbital Diseases and Oculoplasty from Aravind Eye Hospital, Tirunelveli. Sir has a huge experience of 20 years of dealing the injuries around the orbit. So he will be talking and sharing his experience on periocular burns and his oculoplastic approach towards managing those kind of cases. Dr. Premanand is a senior consultant and glaucoma services Aravind Eye Hospital, Coimbatore. He is well known for his expertise in this field, and he will be talking to us on tackling glaucoma associated with the firecracker injuries. And my teacher and an excellent speaker and Chief of Retina Services, Aravind Eye Hospital, Madurai, Dr. Naresh Babu sir, will be speaking on the posterior segment issues associated with the firecracker injuries. And to conclude, finally, Professor Dr. Namrata Sharma will be talking to us on prevention and advocacy and the role of All India Ophthalmic Society. Thank you. We can, by this, is ready, we can start the first topic. We can have a small discussion after the first two talks.
Able to hear me? See my slides?
Yes.
Yes.
Thank you. Good evening to all. First, I would like to thank Dr. R.K. sir and Revati ma'am on the TNOA for the opportunity given. My talk is on pathophysiology of firecracker injuries. Firecrackers are thought to have originated from China, and they are used commonly for festivals during Diwali in India and New Year Eve globally and Independence Day in US, in all important days in various parts of the world. Unfortunately, they are associated with very worse bodily injuries and permanent disabilities and even death. The ocular injuries contributes to around 16 to 31% of the total firecracker injuries. They are of a serious public concern as they affect young males, causing severe, devastating, and permanent effects on the vision, cosmetic, and professional functioning. There are many types of fireworks, and apart from causing ill effects, ill health issues on the various organ systems due to the metals and particulate matters and so many polluting gases in the firecrackers. It also causes pollution of air, land, and sound. If not handled properly with care, it can be extremely dangerous. And these types of ocular injuries are of a very poor prognosis, as the ocular damage here, it is due to all the three effects of the firecrackers, like mechanical, thermal, and chemical effects. So what is actually there inside the firecrackers? The firecracker is made up of a cardboard or a plastic. The propellants are usually the flash powder, carbide, smokeless powder, and the black powder. Black powder is the igniting material, and it is a basic material present in all the firecrackers. So it constitutes 75% of potassium nitrate, which is dangerous to the eye, and 15% of charcoal and 10% sulfur. And apart from this, there are many coloring agents that have been added for all the firecrackers recently to the copper, strontium, calcium, etc. All these metals are dangerous to the human organs, skin, and the eye. So just a brief note on the firecrackers. The firecracker anatomy, it consists of a main fuse, and this is the main fuse, and this is the secondary fuse. So this is the main fuse and the secondary fuse, and at the bottom there is a lifting charge. So the main fuse has a paper around it. When this is ignited, the main fuse which is present inside has an alternating black powder and the non-black powder areas. That is called as time delay fuses. So whenever this main fuse is outside is ignited, it reaches the time delay fuse, and the secondary fuse gets ignited. Again, the lift charge, that is the black powder which is present at the bottom of the cracker, it gets ignited and it acts as a propellant for launching of the motor. So all these red stars, green stars are nothing but the black powder which are mixed with the binders and the coloring agents. So for the attractive colors that appear during ignition. The mode of injury, most commonly 51% it is due to the misuse behavior, and 31% it is due to device failure, and 18% it is innocent victims, that bystanders who get involved with the firecracker accidents. So the ocular damage, as I mentioned earlier, ocular damage results from the mechanical, chemical, and the thermal effects of the firecrackers. Mechanical impact is mainly due to the pressure that is involved during ejection. It can be direct or indirect impact after hitting any ground substance. So usually the indirect effect is similar to the mechanical trauma which occurs. So the mechanical injuries can be open globe injuries, that is a full thickness injury involving the eye bone, or a closed globe injury with a blunt force. So this Birmingham eye trauma terminology system has been used to classify these mechanical injuries, and the open globe injuries are again classified into 4 types: rupture, penetrating, perforating injuries, depending upon the site of injury and the inciting agent. Rupture is caused by usually a blunt object, penetrating by a sharp object. Perforating has two entry sites, that entry and the exit side, 2 full thickness wounds. So the grading is also done based upon the visual acuity, and the pupil positive or negative, mainly depending upon the afferent pupillary defect, and the zone of involvement. Zone of involvement, it gives an insight into the number of anatomical structures that are involved. Similarly, the closed globe injuries are also clinically assessed with the type, grading, and pupil involvement and the zone of involvement. So this is a case of a cracker injury, open globe injury with a corneal tear, with a few cracker materials at the tear edges, that is incorporated in the stroma. There is iris prolapse and the vitreous prolapse with a mucus plug here. At the surrounding cornea is hazy, like stromal edema, and anterior chamber is flat, and the few black clots are there in the anterior chamber. This is another case of a closed globe injury in which a small boy had multiple foreign bodies in the facial subcutaneous tissues, which is referred to as facial tattooing in the context of firecracker injuries, a periorbital swelling, and burnt eyelashes. This boy can have a clear cornea inside because of the reflex blepharospasm, or only the traumatic cataract may be there, or a corneal afflictions with multiple stromal foreign bodies mixed with the black powders can occur. So usually the foreign bodies which occur come out of the firecrackers are usually calcium chloride salts. They are orange in color, so they are calcium chloride salts, or black when they are mixed with a black powder. Usually the lead particles are mixed with the black powders, and they cause much more injury to the cornea than the calcium salts. Managing the full thickness corneal or scleral injuries is not so difficult, but the point to be noted is imaging to rule out the intraocular foreign body is a must. And the decision making on the cataract extraction, either as a primary or a secondary procedure, also has to be decided. And very important thing is role of wound exploration. So the wound has to be explored all around, and to look for any other multiple sites of tear also can be present in case of firecracker injuries, has to be explored thoroughly. And removal of the foreign bodies and which are stuck over to the ocular surface have to be adequately removed without delay. These are posterior segment manifestations, would be dealt by Dr. Naresh sir later. And as we just saw that so many chemicals are there in the firecrackers, and they cause so many health hazards. They are poisonous to the respiratory tract. They irritate the eyes, nose, throat, etc. And the chemicals, they don't they don't occur alone. The impacts of chemical will not occur alone. They are overlapped with the thermal and the mechanical injuries in case of firecracker accidents. The acute tissue damage from the ocular burns, it depends upon several factors like the chemical and the physical characteristics like the pH, the temperature, and the force of the impact, and how the chemical reacts with the ocular surface. Usually the magnesium hydroxide, which is present in the firecracker, they cause devastating injuries due to both thermal as well as chemical effects. They are usually alkalis and which are lipophilic and more likely to penetrate deeply into the eye than the acidic agents and cause liquefactive necrosis of the tissue. So in addition to the routine, once the immediate insult has been taken care of, care should be taken to minimize the inflammation and to promote reepithelialization. The role of wound exploration again is very much important in these cases with the thorough wound wash and foreign body removals. Amniotic membrane grafting, it has to be applied in all cases of moderate to severe grade injuries as it promotes as it has an anti-inflammatory, anti-fibrotic properties, and also it promotes reepithelialization and replaces the necrotic conjunctiva. In few cases, amniotic membrane graft fails. It is like in cases of scleral necrosis, wherein the tenonplasty offers a bridge for the migration of the conjunctival and limbal derived epithelial cells. So the classification systems for grading and severity of the initial injury are useful in guiding and providing an estimation of prognosis. So the thermal burns, as the name goes, there are two types of thermal burns, flame burns and the contact burns by the Duke Elders classification. Flame burns are caused by the fire and contact burns by the contact with the hot objects. So the grading for the clinical assessment include grade 1 and as I mentioned, the thermal burns also, they get overlapped with the mechanical and the chemical. Usually the chemical agents and the thermal burns, they go in hand in case of firework accidents. So clinical grading involves grade 1, lid swelling, burnt eyelashes with mild skin erosions around the lids and conjunctival hyperemia. Here the cornea is not involved. In grade 2, there is blisters and superficial necrosis in the skin around the orbit and superficial corneal erosions, in which the epithelium burns and it has a ground glass appearance. It gets coagulated. When the coagulated epithelium is removed, underlying stroma appears clear. And the grade 3 is the extensive and deep damage to the ocular tissues, wherein the thermal effects can cause severe limbal stem cell deficiency and scleral necrosis and ocular ischemia. And grade 4, the damage is that it requires evisceration or exenteration. So in thermal burns, whenever there is epithelial defects, extensive defects, it can, due to the limbal stem cell injury, there may be persistent epithelial or stromal burns. So this may lead to a progressive stromal coagulative thermal necrosis, and it may end up with scar and pannus formation, or secondary infection can happen with which may be usually resistant to medical treatment. If this heals, can heal with symblepharon and pseudoterigem, or in worst cases, endophthalmitis may result. So this is a case in which the grade 2 superficial skin burns over the eyelids and forehead is seen in the image. And the anterior segment revealed the epithelial defect, the stromal edema with the limbal ischemia involving 3 clockers and exudative debris. Following on 10th day, leukomatous opacity appears with the stromal edema and inferior vascularization with the inflammatory hypopyon. After 1 month, due to the fibrotic response, there occurs symblepharon and pyogenic granulomas. Even after repeated release of symblepharon or excision, the granulomas also can recur, and symblepharon also can recur, and pseudoterigem formation can occur. So, like the long-term sequelae is very bad in cases of firecracker injuries. Hence, the prevention of this is more important, and dealing with it in the acute phase is a challenging thing. Because early placement of the amniotic membrane and deciding on the tenonplasty for the ocular surface long-term sequelae, like to prevent the ocular surface long-term sequelae like corneal neovascularization, limbal stem cell deficiencies, corneal MELS, the symblepharon, ankyloperiphron, all these conditions is really a challenging situation in these severe cases. So additional procedures like conjunctival limbal autografts or select simple limbal epithelial cell transplants, and even for visual rehabilitation, keratoplasty may be required in future. So combining all the 3 effects, the grading of the firework traumas, like a mild firework trauma will have a low-grade chemical injury with the gunpowder afflictions in the periocular, conjunctival, and corneal tissues, with burnt eyelashes, redness and skin wounds, and swelling around the orbit. Moderate trauma will have a small conjunctival lacerations and foreign bodies with extensive superficial periocular burns and chemical burns of grade 3 with the hyphemas and no actual intraocular defects. Severe firework trauma will involve chemical injury of grade 4, limbal stem cell deficiency, which is complete, and orbital fractures, or the corneal scleral choroidal ruptures or perforations and lens-related issues. So in our hospital, from 2014 to 2021 data, so it is the firecracker injuries are consistently decreasing in our hospital since 2014. Last year it was the lowest. Might be like it was as it was mentioned, it may be due to the Tamil Nadu government's restrictions of time in the morning hours 6 to 8 and 7 to 8. That was the reason. But last year we also had some climatic conditions, like we had heavy rains during the Diwali time. Maybe that was also a reason. But it is good to note that the cracker injuries are less. It is definitely becoming less nowadays. So the take-home message is that the emergency management with the removal of the cracker material from the ocular surface and medical management and timely surgical intervention will definitely prevent the long-term sequelae, and multidisciplinary approach is necessary to maintain a normal anatomy and physiology of the ocular surface. In no hope case, measures to be taken to at least improve the cosmetic appearance. Wishing you and your family a very happy and a safe Diwali. Thank you.
Thank you, Dr. Anita, for the excellent overview of the pathophysiology, and also like the details about the firecracker as such. It's very important. And now I call upon Dr. S.K. Rao to talk about the management of ocular surface burns. After this, we can have questions about these 2 topics. Thank you, Dr. Rao.
Thank you, Dr. Revati. I'd like to thank Dr. Ramakrishnan and his team for the invitation to speak today. My purview is to talk about the ocular surface burns that can sometimes occur with these injuries. Whenever we want to tackle ocular surface burns, the first thing would be to grade them and see how bad it is. And this was the classification that was first described by Roper Hall installed in 1965, and it has stood the test of time, and we've been using it until very recently. One of the main problems with this classification is that whenever you have a degree of limbal ischemia which exceeds 50%, the Roper Hall classification prognosticates the outcome as very poor. About 2 decades ago, Harminder Dua recognized that our techniques of managing these injuries have improved considerably, largely because of our knowledge about the limbal stem cell and our ways of grafting it onto the eye. And therefore, he recognized that even an eye with about 9 clock hours of damage, 6 to 9 clock hours, about 75% of limbal damage, tends to have a good to guarded prognosis. And even above 9, you have a guarded prognosis. And it's only when you have a total limbal deficit of all 12 clock hours is the prognosis very poor. Therefore, he suggested that we must look at the limbal involvement in terms of clock hours. And he also added the presence of conjunctival involvement in quadrants of the 4 bulbar surfaces in the task conjunctiva as well. And he created an analog scale where we put each of these as numbers itself. The reason why this is better is because sometimes you may have less than 3 clock hours of limbal involvement, but that person may also have a 50% conjunctival involvement, and then you don't know whether to put him in grade 2 or grade 3. So the analog scale actually documents exactly what is happening on the surface, and this is the classification that we would generally like to follow today. As was mentioned, the first management guide is to do copious irrigation. But unlike a pure chemical injury, like Dr. Anita mentioned, most firecracker injuries also have a projectile or a mechanical injury. Therefore, before you start to copiously irrigate the surface, please make sure that there is no penetration of the ocular coats. And another very important point to remember is that you must do a visual assessment first before you start irrigating. It could be something like light perception, hand movement, doesn't matter. You don't need a Snellen acuity. The reason is that if you take the patient immediately and start washing the eye thoroughly, and later on find out that the patient was NLP, even when he came in, he can medico-legally claim that it was your intervention in irrigation that caused him to lose sight. Therefore, please document at least PL before you start to intervene. The copious irrigation is with about 1.5 liters of fluid or for about 15 minutes, and a buffered solution like Ringer lactate or BSS is better than normal saline or water. But really the best is something like an amphoteric like diphoterine, which basically neutralizes both acids and alkalis. And if there are PGs listening, for the exam point of view, when you're looking at the litmus paper, remember that acids turn blue litmus red, D and D, and a base turns red litmus blue, E and D, so it's easy to remember. And we keep irrigating until the optimum pH of between 7 to 7.4 is reached on the ocular surface. As we saw in the pictures shown earlier, there's a lot of particulate matter in a firecracker injury, and these must be thoroughly removed. And this is the technique of double immersion, which allows you to go deep into the fornices. After topical anesthetic and flipping the lid, you can use a Desmar's retractor to pull up the folded lid, and this will show you if there's anything hidden in the fornix. And these can either be irrigated out, or after topical anesthetic, you can take them out with a cotton bud or with a forceps. For irrigation, after the initial vigorous irrigation, for a more slow controlled process, if you have access to a commercial scleral irrigating contact lens like the Morgan lens, you can do the irrigation in a very slow and controlled manner, and most institutions are likely to have this as well. Inflammation is a key part of the damage that happens on the surface, and therefore you need to use topical steroids extensively for the first 10 to 12 days. There is some concern that these steroids may cause corneal melting if used beyond 2 weeks because they tend to inhibit collagen synthesis. But in many of these badly damaged eyes, the inflammation does not stop at 2 weeks. Therefore, you do need to consider continuing the steroids maybe at slightly lower doses even beyond 2 weeks, and using alternate methods like amniotic membrane grafting and other techniques to try and counter the corneal melting. Because you have a raw surface and you're using steroids, you must of course always beware of infection. The epithelial defect is easy to see. Sometimes the ischemia is not. But the ischemia is equally important because it promotes the non-healing of the epithelial defect, and because the necrotic debris releases a lot of noxious substances, you may want to do a debridement and remove all the necrotic debris. Particularly in firecracker injuries where a lot of the damage is by means of a thermal mechanism, This is a more dangerous coagulative necrosis because this can result in delayed ulceration on the sclera and the cornea. Therefore, because of ischemia, sometimes it's not nice to see a white eye when they come into you with extensive burns. I'd rather see a red, angry eye because a white eye is a very ominous sign which indicates extensive ischemia. The problem with ischemia is that it will interfere with all subsequent efforts for you to repopulate the corneal epithelium using limbal stem cell transplants. And therefore, one of the goals of the primary treatment is to try and re-establish the vascularity in the ischemic areas. And we do this by a technique called tenonplasty. Most of the burns is on the ocular surface. And if you go retroequatorial, the tenon tends to be healthy, contains its own deep blood supply. So if you go between each pair of rectus muscles and look for this deeper tenon flap, you can pull it up and suture it to the limbus, and these healthy blood vessels will try and repopularize or revascularize this area. You have to take care when you're using these 4 flaps from each quadrant to use good relaxing incisions so that you don't end up shallowing the cornices as well. So finally, the management of an ocular surface burn hinges on the epithelial defect. This can be corneal, limbal, and conjunctival, and if it's a very small area, most healthy eyes will heal within the next 24 to 48 hours if you can prevent an infection. We are mostly concerned with burns that damage the stem cells of the ocular surface. We know definitively that the corneal stem cells reside in the limbus, and we think putatively that the conjunctival stem cells are present in the cornices. And therefore, when you're looking for damage on the surface, these are the 2 areas that you'd like to focus on. Because if the stem cells are lost, there will be a persisting corneal defect, which will go on to symblepharon, ankyloblepharon, and keratinization and make your subsequent rehabilitative maneuvers harder. All our efforts in this area are geared towards preventing a corneal perforation by restoring the corneal epithelial surface, because if you have a corneal perforation during the acute and subacute phases, it alters subsequent prognosis significantly for the worse. So if you have a burn like this, it is easy to look for the limbal loss. As you can see here, the limbus is quite unhealthy in this burn. And you can compare this with the fellow eye which has not been affected, and you can see the healthy palisades here. You can see some pigmentation here, but this will often slough off in the next 72 to 96 hours. And therefore, this will give you 2 caveats. The first is, when you have severe burns, you have to reassess them every day, and your prognosis and grading may change with each visit. Second, it is not good to give the parents or the patient a very rosy prognosis right on day 1, because much of the damage and changes that we see in these severe burns tends to occur in the subacute and the chronic phases, and therefore we must always say that the prognosis in these severe burns tends to be a little guarded, and we can only keep prognosticating as we go along. If you have a burn like this, oftentimes there may be deeper limbal stem cells which are present deep in the palisades which are surviving, and so you can attempt a stem cell rescue using the good properties of the amniotic membrane. So in this burn, you can see that really a limbus to limbus and conjunctival staining with fluorescein. So you use an amniotic membrane which goes right from one lid margin into the fornix, across the bulbar surface, the other fornix, and up to the other lid margin. When you do this slowly, sometimes if you're lucky, some of the surviving stem cells will catch up, and in 6 weeks you can see a reconstruction of the ocular surface. By 3 months, there is a localized limbal deficiency here which causes this conjunctivalization. You can debride this, put in another amniotic, and 6 months from the time of injury, you have a surface that's been reconstructed fairly well. If you end up in the subacute stage with a partial limbal deficiency from the burn and this kind of a localized pannus involving the visual area, you can move this pannus off by scraping, and usually the surrounding limbus and the normal corneal epithelial cells will take over this area, and you can do this with or without amniotic membrane. If you have more extensive limbal damage and a pannus covering the entire cornea as in this affected eye, and if you have a normal fellow eye, in the earlier days, we used to take 2 clock hours of limbal tissue from the superior and inferior cornea and use it to reconstruct the affected surface. But today, we do it with a much smaller biopsy from the healthy eye, and we call it SLET, a simple limbal epithelial transplant, pioneered by the group from LV Prasad. So if you have a burn that ends up looking like this with a moist surface, you have a healthy fellow eye, you remove the pannus from the surface, use an amniotic membrane as a bed, and then from the small 1 to 1.5 clock hour biopsy, You put these little bits of limbal tissue onto the amniotic membrane. You stick them with fibrin glue, put a contact lens on top, and over the next 6 to 8 weeks, you can have a reconstruction of the surface because each of these cells is now proliferating and spreading out and covering the corneal surface. Sometimes, however, you can have a combination of all of these bad things happening in this eye. Like here, you have a limbal stem cell deficiency, you have extensive corneal thinning and scarring, and you have an inferior symblepharon. But luckily, if this person has a healthy fellow eye, you can try and reconstruct this using some of the principles that we just saw in the earlier slides. So you start by doing a peritomy, and normally in these limbal reconstructive procedures, you do a fairly limited peritomy, although it's 360 degrees, just going about a millimeter or two away from the limbus. But in this person, because he also had an extensive inferior symblepharon, and we'd like to reconstruct that as well, you dissect deeper until the inferior edge. You then have to peel off the pannus, which is the vascularized conjunctival tissue that is growing onto the cornea, so you can expose the bare stromal surface like this. Now this is very thin and scarred, and therefore here, the thinning extends almost up to the inferior limbus, and therefore there's no question of doing a penetrating graft in this situation. Therefore, we are going to do a lamellar procedure here. You cannot get a big air bubble to form like Anwar described in these scarred, unhealthy, and vascularized tissues, which are very thin in places, and therefore you have to do a manual dissection. You do a patient layer by layer dissection, and the way to know when you're deep enough or at 90% depth is by looking at this peripheral margin of the wound. And for those of us who do corneal transplants and have an idea of how thick this peripheral cut edge should be, this gives you a clue as to when you are at 90% or so in this case. So you're doing a pre-decimatic talc here, and at 90% there are very few keratocytes in the corneal stroma, and therefore once you reach this particular plane, your interface will have very minimal scarring. So you keep working patiently until you excise all of the scar tissue and reach a depth of 90% in the bed. And then you can bring a donor tissue on, and this is just like a dart. You just have to ensure that the donor tissue has a good stromal clarity. We don't really care about the endothelial health because we have the host endothelium here as well. This is the donor tissue taken from the fellow eye, and you can see the limbal cells being harvested in this biopsy here. The pigmented palisades are seen here. Once you've got this, you put it aside in a little bowl of saline, then go back to the patient's eye and remove all of the epithelium from the talc tissue because you don't need it now. We're also trying to reconstruct the symblepharon. So basically, we're using the fibrin glue, both thrombin and the fibrinogen. And then you take a large piece of amniotic, which you can put over the surface and layer it under the cut edges of the corn. And this will try and help you protect from symblepharon formation. So these are the bits of limbal tissue that we harvested, and a BCL has been put on the eye. And if it all works out well, you can get a decent reconstruction of the affected eye. And therefore, what started off looking like this can look like this at the end of your procedure. If the damage is even more extensive, then you have to take recourse to a keratoprosthesis. If it is a moist eye, you can use a Boston type K-Pro to reconstruct the surface. And if it is a very dry keratinized surface, then really the only option we have today is the osteoodontokeratoprosthesis. So the ocular surface burns basically can run a gamut of changes from a small central epithelial defect, which will heal in 24 hours with just lubricants and a mild antibiotic, to somebody in whom the entire surface is destroyed and you have to do 2 6-hour procedures to reconstruct the surface. But the principles of managing them is what I tried to share with you in the last 8 to 10 minutes. And I'd like to thank you again for the invitation to be here today. Thank you.
Thank you, Dr. Rao, for this wonderful overview of all the management possibilities in ocular surface injuries and firecracker injuries. And now I would like to call upon the panel to give their opinion, share their experience, and also to start the discussion. Dr. Reddy?
So most of the things are covered very well. One thing what we noticed is the injury looks a little bad, and the burns on the legs and everything. And we try to manage with irrigation everything. Then suddenly next day you see endophthalmitis. So gone for because of small particles gone inside the eye, which we cannot see, because of the hazy cornea. So that's one few cases we have surprises. So from that time onwards, we are taking them under general anesthesia, and the general anesthesia, if any doubt is there, we are giving intravitreal or intracameral antibiotics. We are not taking a chance to see enough calamities set up. So prophylactically, if on examination we suspect penetration of particles inside the eye, then we are going for a prophylactic antibiotics intravitreal.
Yes,
And
it's
most of them is bilateral cases, many times. So it's a very devastating if they develop bilateral endophthalmitis. If infection is controlled, somehow we can restore some vision, like so many techniques Srivastava has shown. But once it's infected, we cannot do anything.
and these cases I have noticed not only infection, even the chemicals, if they has gone into the vitreous, they can cause severe chemical vitreitis and toxic vitreitis. That kind of problem also can occur.
It's very difficult, madam. Very difficult to differentiate whether it is due to the inflammation is due to the trauma or due to just foreign body reaction, or it is a infective element. It's very difficult, and so it's confusing. So whenever we suspect, we are giving intravitreal antibiotics. At least one part is taken care.
Vasanta ma'am.
I thank Dr. Revati and RRK for giving me this opportunity. Now, those days, ours was the only eye hospital with casualty when we were students and early days of my assistant surgeon work. And Nirmal was not in our unit. So we all had to do duties on Diwali days, and we used to dread those duties because all severe injuries come to our hospital, and it was heartrending to see all the small children with very severe wounds in the cornea and in the globe. As Dr. Rao's lecture, as usual, was very informative and clear-cut, with full of very good information how to treat and all that. And as he said, we should never give a good prognosis. By looking at the white eye, we may just say, okay, everything will be normal, and that will be, we will be in soup after that. And giving the guarded prognosis is very important, and prevention is better than cure, especially in this type of accidents. So this is some accident which can be easily prevented, and I think government should insist all those crackers should be burnt only in association, and like in a flat they can burn it in a group or in a club, like that, so that the timing also will be controlled, and there will be some control over the children, because they are the ones who are very much affected. Because in our hospital, we did a study, and because it's been cases have been referred, we have seen that more than 50% of the injuries were to the bystanders. So we have to keep on. We do tell them in the TV. We have so many information being passed on, but it should be repeated again and again. And this is the first time, Dr. Anita, how I knew how those crackers burst. That was a good information. And as Anita said, I hope we get rains this time also, so that the number will be less. Thank you.
Thank you, ma'am.
Can I ask a question, Revati?
Yes, sir.
First of all, let me compliment Anita and SKR for the wonderful talk. Very informative, and learned a lot. I just want to know, because we have seen many patients with cracker injuries with severe lid edema. They're not even able to open the eye. Okay, severe inflammation. Their patient is also a little toxic. Okay, in those cases, how do you examine the cornea? How do you examine the globe? Is there any way of doing it? Sometimes you have bilateral severe. I've seen something like a blast injury they have, and they're not even able to open the eyes. Even if you put a Desmas retractor, is very difficult to open the eyes. So much of edema is there, and by the time you treat them, and sometimes you may lose the eye as well, because there can be an underlying corneal problem or even a ruptured globe for that matter. So how do you tackle such a situation?
Dr. Rao?
I think basically that kind of severe injury, sometimes they may have other life-threatening injuries as well. So first we have to triage and make sure that that is not there. If that is not there, like JK said, the only way in these really severe ones would be to put them under GA. I mean, you'll have to put them under GA, and only then can you, everything with the spasm is what is fighting you. So you're trying to pull the lids apart with some speculum or with a retractor, and there's a significant spasm. So even if he's trying to help, he cannot. And topical anesthetic in these kind of patients will not really work. So generally, you need to put them under GA, look at it, and like JK said, if you find any injuries, then you already have spoken to them, taken a consent. You can go ahead and try and fix it, whatever it is, either a primary repair or, like JK said, you need to inject something into the eye to protect from infection or whatever. So I think in these very bad cases, like the ones you're describing, bilateral injury, blast, face gone, you may need GA. I don't see any other way you can do it. Because otherwise, if you're trying to push and pull and try and open the eyes apart with a lot of force, and if you have a perforation or a globe trauma underneath, you may actually be making him worse rather than helping.
Absolutely. Thanks a lot, Esther.
Revati ma'am, can I add one point, ma'am?
Yeah.
Yes. Like what ma'am said, like we used to get around 70 to 80 firecracker injuries every Diwali day. In the past 2 years, like what Dr. Anita said, it has come down definitely because of COVID, and hope there is no revenge firecracker bursting this year, post-COVID. Like what sir said, we had a pediatric case, ma'am, and it's very important. I just want to stress on one point. This pediatric firecracker injuries, that girl came, that 6-year-old girl was unable to open the eyes at all, totally. And 2 days we couldn't even see properly. So we put we took her under GA. And when we examined, there was an incense stick, a part of an incense stick on the udbatti, what they used to burst crackers. That part, the tip of the incense stick was under the lid. And that was causing the trouble and all that. And she refused to open her eyes at all. So we had to examine her under GA. And eventually she went for something like what Dr. Anita pointed out. She had a panis with simplifron, and finally we had to take her for a simplifron release with conjunctival limbal autograft after a few weeks. So it's very important to examine them under anesthesia if at all it's necessary, because we wouldn't have thought that it's a incense stick. It was just a tip of an incense stick.
Yeah, with edema, if there is severe, the child or the patient is not able to open the eyelids, but not much of edema or chemosis, then you have to suspect a foreign body. Most of the time it will be there that you have to suspect. And I wonder in such cases, before even going for anesthesia, if possible, just put a ultrasound probe just over the edematous lid. Will it give any idea of rupture globe or anything? I don't know. I'm just thinking maybe Naresh can give explanation about this later. We'll move on to the, if there is no other question.
One simple question, Revati, can I ask?
Yes, sir.
Suppose sometimes we see multiple corneal foreign bodies in different levels of corneal superficial, deep, stromal, something like that. So what would you do in that case?
If it's deep-seated, we can leave it like sir.
Deep-seated, we can leave it. Okay.
Generally, we wait for sometimes. Wait for a few months also.
Yeah, that's what.
When the visual, reasonable visual acuity, 618, even 636, 624, 618, we leave them. If worse than that, then we plan for either a lamellar captoplasty or a penetrating captoplasty. Both eyes. Usually one eye is good, one eye is a little bit less vision also. We just leave them because the prognosis is not that great in these cases.
Commonest is that orange stuff that Dr. Ranita showed, which I just learned today was calcium chloride. If they are not protruding, like they said, we can leave it. The only problem I've seen with them, they have an intractable photophobia. They have the scattered spots throughout the cornea. They will be seeing 612 to 612 parts because it's scattered in the pupillar area, but they have an intractable photophobia, which takes a very, very long time to go. I don't know if it goes. I think they just stopped coming to see me. Used to see this a lot during my SN day. JK, have you seen that? Do you do anything special for the photophobia?
No.
No,
Because if
most
it's
cases only will need DALK or something later. Very severe photophobia. And you try to remove them also will lead on to scarring.
more scarring,
Multiple
more
scar.
scarring.
Yeah, so better to leave them. But sometimes, as Sanita pointed out, if it is magnesium or something, the deep foreign bodies, you can see lysis around them, and gradually, like the toxic keratitis, you can see. Such things we may need to remove. We have to dig them out. But if we lead on to scar, but later we can manage them with keratoplasty or something. Otherwise, we can just wait. Inert foreign bodies, we can wait, but later they may need some intervention.
But usual prognosis is not very good, madam. They do fail. No, eye looks very quiet, no vascularization, and without prognosis will be very good. But it's not that great. After 4 or 5 years, again, they fail, most of them.
We'll move on to the next topic. It's about the periocular injuries and oculoplastic management by Dr. Manak Shah.
Good evening to all. First, I thank RK sir and Revati madam for giving me this opportunity. I am going to talk about periocular bags and oculoplastic bleed. Facial bags commonly involve the eyelids. Eyeball is usually protected due to blink reflex, Bell's phenomenon, protecting movements of the arms and head. These ocular sequelae are usually secondary to post-band eyelid deformities. So appropriate early intervention is needed for better outcome. It is a general types of bands affecting the lids like thermal bands, chemical bands. These are mostly related to firecracker injuries. And other causes like hot liquids also may cause thermal bands, and acid alkali substances may cause chemical bands, and electrical bands due to contact, direct contact or flash band, and radiant energy bands due to ultraviolet rays, lasers and welding arcs. Thermal bands, usually most of the flash bands are superficial. As because of blink reflex, they are superficial only. In flame bands, the period of exposure is little longer. So that is an important factor which may result in deep bands. Chemical bands, as all of you know, the alkalis are more dangerous. That cause saponification of cell membrane and causes cell disruption and death, causing liquefactive necrosis. Whereas acid causes protein coagulation, so it limits further penetration. And history taking is very important. In case of fire injury, you have to ask about timing of injury, how it happens. Not only firecracker, any type of bands. You have to ask what are the types of injuries, and also duration of exposure is important, already mentioned. And any use of protective devices at the time of injury, and any history of any first aid treatment already taken. Coming to the evaluation, you have to evaluate. Initial evaluation is very much important. Skin and outline area of the band is very much important. As already Mohan Rajan sir pointed out, initially there will not be much lid edema. Later on, they may develop difficult to examine. So as early as possible, we have to examine inside the eye also. And Bell's phenomenon is very important. If the patient is having good Bell's phenomenon, the corneal complications will be avoided. And we have to look for eyelash loss to predict the margin involvement. And entire ocular examination is must. And whenever we are suspecting foreign bodies, we have to do CT scan. And late evaluation, we have to look for malfusion of the eyelids, such as ectropion, entropion, and trichiasis. And also we have to address the lag of thermus. These are the general classification of the eyelid bands. Actually, it is a first degree bands involving the epidermis only. Second degree bands involving the papillary region of the dermis. Third degree bands involving the reticular region of the dermis also. Full thickness, it involves underlying subcutaneous tissue and muscle. So these are the types of eyelid bands. Usually first degree bands does not produce any deformities. Second degree bands, it will produce subcuticular or dermal fibrosis with sparing of the argillaris fibers leading to ectropion only. Third degree bands, there is a muscle involvement also, so which leads to severe ectropion and lid shortening. At the same time, you have to look for adjacent soft tissue bands like cheek, nose, forehead and temporal region. All these things will cause severe skin contraction, so which displaces the eyelid. Superficial bands usually having clinical features of blanching erythema and blistered erythema. Sometimes it may present as white featureless thickened skin with areas of numbness. Deep bands usually present with soft necrotic skin with exposed deep tissues. There is a edema and tissue whitening and progression to the ischemia and eschar with possible superinfection. These eyelid bands you have to carefully observe for any loss of eyebrow and eyelash hairs, and there is a concomitant laceration. Some cases may have eyelid avulsions with canalicular laceration. This is very important. You have to identify these canalicular lacerations. Some patients have orbital compartment syndrome, that is a severe paroptosis with restricted movements. That cases you have to do immediately intervene. And contractures and eyelid malposition occur usually after 2 weeks. Some cases may happen early also. This is a natural healing of the wounds. Epidermal bands usually heal within 5 to 7 days. Superficial dermal bands heal in 1 to 2 weeks. These are the dangerous deeper dermal bands. It takes around 2 to 3 weeks to heal and it produces so much contraction and complications. These are the complications of the eyelid bands. If it is untreated, it may go for dry eyes because of involvement of sweat glands, lacrimal glands. There is decreased tear production, and there is a lack of thermus already pointed out. Because of that, there is a severe exposure keratitis, corneal ulceration, perforation, everything will happen. Thysis bulbae, and ultimately patient lose the vision also. And eyelid anomalies like trichiasis, entropia, and ectropia. So all these complications can be prevented if treatment taken immediately. And coming to the management part, first our aim is we have to stabilize the patient and we have to concentrate the maintain the airway. Then we have to examine the globe. This already I pointed out. Once lid edema develops, difficult to examine the globe. And we have to remove the dirt and slough the skin as far as possible. And wound irrigation already told by previous speaker. And at the same time, you have to seat the pharynxes with moist cotton tip applicators to remove any foreign materials. And we have to trim the band eyelashes with ointment covered scissors. And at the same time, you have to give broad spectrum systemic as well as topical antibiotics. Usually corneal ulcer, the pseudomonas infection is more common, so you have to use topical antibiotic drops. And always you have to liberal use of lubricating eye drops. Already I pointed out, because of lack of thermus, exposure keratosis, everything will be there. So we have to use lubricating eye drops frequently. And topical bovidin iodine ointment, silver sulfatizing cream, silver nitrate solution, and mupirocin ointment should be used for skin over the face. And polysporin ophthalmic ointment can be used on the lids. And we can apply the lubricated dressing such as zero form gauze or alginate dressing. And coming to the early surgical intervention, as already pointed out, if the patient is having signs of orbital compartment syndrome, then we have to do lateral canthotomy and cantholysis to relieve the pressure within the orbit. And other surgical procedure, if there is a severe lack of thermus causing exposure keratopathy, we have to consider torsorrhaphy. There are different types of torsorrhaphy like suture torsorrhapy, surgical torsorrhapy. Just I will show one video about suture torsorrhapy. Here we are making 2 raw areas at the lid margin, upper lid and lower lid, at the lateral 1/3 of the lid. So this raw area will be occluded by our sutures and bolsters. So this is a bolster. We are using 40 silk or proline. Then by use of 2 bolsters, we can take it from the 4 mm below the lid margin and along the gray line, and it should be come back through the same direction. And we are tying with the 2 bolsters. So thus we are keeping 2 lids close together to prevent the complications. So this is a simple technique which can further to prevent the further complications. And other intermediate stage, our aim is to alleviate the lack of thermus, and we have to release the contractures, and you have to prevent the malposition. At the same time, you have to treat the infections. And grafting also always you have to keep in mind. Usually it should be done in 1 to 3 weeks after injury. And this is also important step. Excision of the necrotic eschar can be performed to prevent the infection as well as to release the contracture. Then lacrimal system injury also always you have to take care. As a oculoplastic surgeon, you have to take care. Whenever there is injury near the medial canthus, you have to look for any punctal problem. If there is any punctal stenosis, you have to do daily punctal probing, and patients should be reviewed periodically. And late stage, if there is a significant punctal stenosis or canalicular stricture, we have to go for punctoplasty and canaliculoplasty. Some cases we have to use canalicular stenting also. It may be monocanalicule or bicanalicular. In late stage, mostly patient will have cicatricial type of ectropion. We have some extensive scarring. So that ectropion we are managing like different techniques. If it involves both leads, we can address both leads at the simultaneously. Main thing, we have to excise the entire scar, then we have to replace that raw area with skin graft. It may be a split skin graft or full thickness graft. Full thickness graft is ideal, and usually we are taking it from contralateral upper lid if it is spared. Otherwise, we have to take it from post-auricular, supraclavicular, upper arm, and sometimes groin. If everything is affected, you have to go for groin also. So here the picture is showing that cicatricial ectropion scar. So we are excising the entire scar and release the scar. After that, this is your post-auricular skin that is placed over that raw area, and we are suturing to that. So it will give good results and prevent the complications also. And this graft always should be oversized related to the recipient side. Small drainage holes can be created using 11 grade with or without drain placement. And sometimes the graft can be glued also. The lid should be immobilized on traction for 3 to 5 days. If it is severely damaged eyelids, already pointed out by other speakers, we have to go for other procedure. If there is no lids at all, then we have to mobilize the peripheral bulbar or fornix conjunctiva to cover the globe. That is musculoskeletal procedure. And sometimes we can use double layered amniotic membrane graft also. And split thickness graft, it can be used from thigh. And Tenon's capsule also mobilized, and it can be sutured to the limbal area. So these are all by doing all those things, we can prevent the further infections and early morbidity to the patient. So these are the management of sequelae. So already pointed out, it is a continuous lac of thymus, persistent lac of thymus. Then you have to go for low lid sling procedure using temporalis fascia or fascia lata. If trichiasis is there, you have to do epilation. It may be multiple times you have to do, and other procedures like electrocautery or cryotherapy can be considered. And sometimes you can we can come across with canthal deformities that you have to do multiple isoplasties and excision of the scar and full thickness skin graft, transposition of the flap. These are the techniques we are using. So as a oculoplastic surgeon, you have to clearly look for any lacrimal system damage, any lac of thymus, any cicatricial ectropia, all those things we have to address all those complications, then prevent the intraocular complications. So I like you to conclude that final outcome depends on proper clinical assessment. First aid measures and initial management is very, very important, and close follow and appropriate surgical intervention. So by doing all those things, we can achieve good results. Thank you for the opportunity.
Thank you, sir, for the complete explanation of the periocular problems. And we will have a small discussion after Dr. Premanand completes his talk about the associated glaucoma in firecracker injuries and how to tackle it. Over to Dr. Prem, please.
Are you able to see my presentation?
Yes, doctor.
Good evening, everyone. Thanks, TNOA, for the opportunity. I'll be talking about tackling glaucoma in case of an ocular trauma. Ocular trauma following injury could be a closed globe injury or an open globe injury. Closed globe injury is more commonly associated with glaucoma than an open globe injury. When it comes to closed globe injury,
Slide show, please.
Yeah, yes, sir. I mean, I don't know what the thing is not working. I tried a lot.
Yeah.
I tried it. It didn't work. Then only that's why I started.
Okay.
No problem.
You can go for Control F5.
Control F5.
Yeah.
Say something else. Fine, sir, I'll just continue with it. Glaucoma following a closed globe injury can be an early or a late onset. Campbell has described 7 rings of tissues which get frequently involved in brain trauma. It could be in iris sphincter tear, iridodialysis, angle restriction, cyclodialysis, trabecular meshwork tear, zonal dialysis, and retinal dialysis. Usually, the presentation following a closed globe injury could be an eye with the increased IOP, low IOP, or even a normal IOP. The causes for an increased IOP following a closed globe injury because of the inflammation, hyphema, or could be a subluxated or a dislocated lens. Patients can also present with low IOP because of the hyposecretion associated with the inflammation following the trauma, or could be a trabecular meshwork tear, which can increase your outflow, or could be a cyclodialysis cleft, which will drain your aqueous to the suprachoroidal space, or could be an occult globe rupture. Always check the IOP. If possible, and the patient is cooperative, check with the appellation tonometer, provided the cornea is intact. I mean, the corneal epithelium is intact, there's no epithelial defect. If not possible, then you can even use an eye care to check the IOP. It is preferable to do defer gonioscopy at least for a week in case of an hyphema, mainly to prevent the dislodge of clot, which can lead to a rebleeding. Inflammation hyphema, the most common presentation in case of a closed globe injury. When it comes to the management, it is basically the steroids for you to control the inflammation. Cycloplegics mainly to prevent pupillary block as well as the control the pain. And for the increased IOP, you can start them on topical anti-glaucoma medications, preferably aqueous suppressants. And you may even give a short course of systemic acetazolamide. Ask them to have a limited mobility so that there won't be any chance of rebleeding. Ask them to have a head and elevation so that the bleeding hyphema will settle down and so that the vision will be better. You can even give vitamin C and ethamsulate for decreasing the chance of rebleeding. You can reassess in a week depending upon the amount of IOP as well as the hyphema. Suppose if the response is better, in the sense the hyphema is decreasing and the IOP is coming under control, you can continue the same and you can taper steroids over a period of time and you can see what is happening. In case if the hyphema is persisting or this hyphema is increasing because of the rebleed, or the IOP is still high, not coming under control with your topical and systemic anti-glaucoma medication, you can go for an anti-chamber wash or a underclot removal. So when you want to intervene, so what are the indications for you to go for an intervention? Suppose if the IOP is more than 50 for 5 days, more than 35 for a period of 7 days, when there is a total hyphema for at least 5 days, whenever there is a sign of an earlier corneal blood staining, in patients who have a sickle cell hemoglobinopathies, if the IOP is greater than 25 or more than 24 hours, it is better to intervene. Coming to the other causes of an increased IOP, in case if there is a subluxated lens, it could be an anterior or posterior subluxation. In case if it's an anterior subluxation, it can lead to a pupillary block and a secondary angle closure glaucoma. So you can do an IAG peripheral iridotomy, control the IOP with your anti-glaucoma medications, and you can plan for an elective surgery later once the inflammation settles down. And this is a picture of a patient who presented with an subluxated lens with the, you can see the nasal zonal dialysis, and he presented with the vitreous in the anterior chamber. The patient underwent vitrectomy with clearing of the vitreous in the anterior chamber. Now he's having a vision of 6.6 and he's not having any complaints. He's not on any glaucoma medications. So the management will be tailor-made for the particular patient based on what is the vision and other issues. Whenever there is a posterior subluxated lens, they try and control the IOP as much as possible with the anti-glaucoma medications, and the rest will be taken care by your posterior segment consultant. Whenever there's a dislocated lens, you can have an anterior or posterior dislocation. If it's an anterior dislocation, it's an emergency because of the chance of going for corneal decompensation. So try and control the glaucoma as much as possible with your medication, and you can take them for lens removal under mannitol cover. If it's a posterior dislocation, your veterinary colleague will take care of it. So not only early glaucoma, even patients who have a normal IOP in the initial period following the closed globe injury can present to you with the increased IOP over a period of time. So the most common causes that you have to think of and keep as a differential diagnosis in case you have a increase in IOP in the later part, or you can have a ghosted glaucoma, that may be an angle recession glaucoma, could be a Schwartz syndrome, could be a closure of cyclodialysis cleft, or a peripheral anti-synaptic formation because of your inflammation induced, or could be an increased TM pigmentation because of the amount of pigments that released post-trauma. So ghosted glaucoma is diagnosis of other conditions, I mean, basically exclusion. What are the basic requirements for you to have a ghostal glaucoma is you need to have vitreous hemorrhage, and it takes at least 7 to 10 days for the RBCs to get degenerated in the vitreous cavity to become non-pliable khaki colored cells, which we call them as ghost cells, and they have to reach the anterior chamber via a break in the anterior hyaloid phase. Only then they can come and block your trabecular meshwork, which can lead to an increased IOP. The initial management will be medical management, but most of this ghost cells won't be drained by your trabecular meshwork, so they have to be cleared from the anterior chamber as well as from the vitreous cavity by means of pars plana vitrectomy. Patients who may have a normal IOP to begin with, or even a low IOP to begin with, can have an angle resistant glaucoma in the later part of their life. The main mechanism is, say, the initial IOP may be normal mainly because associated with an angle recession, you can also have a trabecular meshwork tear, which can lead to a increased outflow. That's why they are presenting with a normal or even a low IOP to begin with. As once these trabecular meshwork tear gets healed by scarring, then the IOP slowly increases. And studies have shown that at least 180 degree of angle recession has to be there for you to have a glaucoma in future. And the initial management will be medical management, which starts with aquasuppressants and prostaglandin analogs. Pilocarpine is not that very effective, mainly because of the scarring of the trabecular meshwork. And in case if the IOP is not getting control with your medical management, then you have to go for a surgical management, which may be a trap or a tube, depending upon the IOP and other factors. Schwartz syndrome is a condition where you have an retinal detachment along with the tear, through which the retinal pigment epithelium as well as the photoreceptors can gain access into your anterior chamber and can block your trabecular meshwork, which can lead to an increase in IOP. The main management will be to do a retinal detachment surgery and close the tear, which will take care of the glaucoma. The cyclodialysis cleft is an important differential diagnosis. Whenever you see a patient who have presenting to you with a low IOP after a trauma, always keep in mind a cyclodialysis cleft. The gonioscopy may be very difficult if the eye is very soft. So initial treatment will be the same. Put them on steroids and try and control the inflammation. And we can do a gonioscopy maybe after a week to see whether the cleft is there or not. Most of the cleft, which is a small cleft, will heal and seal spontaneously. If there's a persistent hypotony and there is a cleft, then you have to go for a management of it. And in case if there's a cleft and if it closes, it can lead to a spike in IOP also. So you have to manage that based on the amount of IOP. PAS can happen because of the inflammation associated with the trauma, and all these things can lead to a increase in IOP. So the basic management will be to try and control as much as possible with your medical management. If you're not able to control with your medical management, then you have to go for a surgical management. Now coming to the open globe injury. The glaucoma following an open globe injury mostly have a late onset than an early onset, mainly because of the open wound associated with the trauma, which tend to have a low IOP. Primary repair is very important in case of open globe injury, mainly because a proper meticulous repair and an AC reformation will help you to prevent the formation of PAS, which in turn reduces your incidence of forming a glaucoma in the future. The causes for you to have an raised IOP following an open globe injury could be your inflammation hyphoma, similar to a closed globe injury. Suppose if there is an associated injury to the lens, it can lead to an intumescent cataract, which can lead to a pupillary block, or if there is a break in the anterior lens capsule, which can lead to a release of the lens particles into the anterior chamber, which can incite inflammation that can lead to an increase in IOP. So basic treatment would be to, along with control of inflammation, you have to take care of the cataract also, remove the cataract. If possible, along with the primary procedure, if it is diagnosed at the time of initial insult. If it is not diagnosed after the initial repair, then you can plan the cataract surgery along with the implantation of IOL, depending upon the amount of IOP and the capsular support. And always don't forget to rule out a foreign body in any patients who have an open globe injury. Gonioscopy may be avoided in the initial 1 or 2 weeks, as long as the epithelium is not healing. Once it is healed, always go for a gonioscopy and just rule out intraocular foreign body. This is a patient who presented, say, maybe several years after the trauma. And if you can see, the patient had an inferior corneal edema, and this is the arrow points out to the penetrating injury, a full thickness scar. When we did a gonioscopy, we found a foreign body which is there in the inferior angle. So this is the cause for the patient to have an corneal decompensation, particularly the lower half of the cornea, and the patient underwent foreign body removal. So take home message, the initial management will be to control the inflammation and control the glaucoma by means of medical management, topical as well as if required systemic. And in case if there's a cause, treat the cause, because most of glaucoma is mainly because of the secondary to bleeding, or could be a lens induced, or could be a ghostal glaucoma. So try and treat the cause as much as possible and try and see whether you can control the IOP with the medical management. In case if the damage is permanent, if it is not getting controlled with your medical management, then you have to resort for the surgical management. The options are available, or you can go for a trabeculectomy or a glaucoma drainage device or a cyclodestructive procedure, depending upon the visual acuity and the visual potential of the patient. And all these patients who had a brain trauma or even an open toe injury, even though they may have a normal IOP to begin with, have to be on lifelong follow-up, as these patients can end up in having glaucoma in the later part of their life. Thank you.
Thank you, Dr. Prem. It was really an excellent talk, completely covered everything. And we would like to have the panelists and Thiru sir or any other panelists to have their opinions and add-on points regarding the two topics which we have covered right now.
This IOP, this intraocular, antechamber hemorrhage with a raised intraocular pressure. As a rule, it is given 5 days, 4 days, wait, a corneal staining comes. It's very difficult to notice the corneal staining in the presence of a full blood clot in the antechamber. Every day looking at corneal staining and draining. Generally, I prefer to go for we wait for 1 or maximum 1 day, 2 days, then you give ethamsulate, so some sort of things which will enhance blood clotting intravenous. Then with adrenaline in the drip, we go for an antechamber wash. We don't wait for such a long time as given in the textbooks. I don't know what Srini, what you will say.
Yeah, agree. Sometimes it is quite hard. So I think all those things about 40 millimeters of mercury for 3 days, 4
very
days.
Painful.
Yeah. So particularly if the cornea endothelium is taken a beating, then the sooner we go in, the better, I think.
You have to keep an eye on corneal blood staining. Earliest sign, even better before that to intervene.
That's the matter. Before that, that is the good word. Before that means from your past experience, that's going to come. It's when IOP is raised and there is a blood clot more than half or more than 2 or 3 days, then it's going to come. So generally on second day or third day, they're so painful for the patient, and keeping them with you also is very difficult unless you admit it. They go to another doctor.
The only concern about doing an antechamber wash little earlier is about the chance of rebleeding, because most of the rebleeding happens about 5 to 7 days. That's when the clot attracts and the chance of rebleeding is here. That's what to say. If the things are improving and signs are getting better, you can wait. Otherwise, you can go for intervention.
Yeah, I always prefer, if the IOP is high, better to intervene early. If it is not, maybe we can wait and observe.
It's a simple procedure. No, it's not like under topical anesthesia, you just going to open and wash it.
Yeah, the procedure is simple, but the rebleed, as Prem said, it can happen. We have noticed that.
Even in the books, madam, but it's not great evidence. The literature. I did a AC wash, I had a rebleed. Like that, there is no great evidence. It's given in the books. I asked many people, many surgeons, what they did. There is no great evidence to show that I did a wash, then fourth rate bleeded. Somebody has written sometime back, long time back. That's all.
Yeah, and I also agree with Prem about the foreign body, that we have to be very careful, especially in blast injuries and cracker injuries. We have to carefully follow them up, and later on also, we can find out intraocular foreign body, and even late onset glaucoma also is very, very common in these patients. So we have to clearly explain to them that a lifelong follow-up is very, very important. Later follow-up also is very important. Arki sir, would you like to add on some points here? Sir, unmute, sir.
Sir, Archie, sir, unmute.
Yeah. I agree with all of you, but personal opinion and what we are doing normally is different. But what normally we know, especially what you people you were discussing about the HIPMA, there are certain things are important. Like the 5 things are important when you talk about the management of HIPMA. One is the nature of blood. And second is the duration, and also third one is the intraocular pressure, and fourth one is the amount of blood, and fifth one is the constitutional factors, symptoms like headache, vomiting. These are all 5 things we have to take into account when you manage a case of HIPMA. Suppose if the blood is grade below the pupillary margin, if it is fresh blood and IOP is moderately elevated, in such a cases, usually within 2 or 3 days, definitely the HIPMA will disappear without any surgical intervention. Suppose the amount is more than 2/3 of the chamber, intraocular pressure is very high, and patient is having severe headache and everything, and blood is altered, then of course we have to go for surgical AC wash. That's a thing. We need not wait for too long. Suppose 4 days, 5 days with very high intraocular pressure, chance of blood staining is very high, and unnecessarily we are leaving the patient with so much of pain and everything. And sometimes it's very difficult to remove the clot behind the iris, and rarely it would go for 8-ball hemorrhage also. But then again, it's very, very difficult to manage. That's a thing. And as far as glaucoma is concerned, no, especially this type of injuries, it is very difficult to pinpoint the cause for glaucoma. Rise in intraocular pressure, especially this blast injury. So in many cases of blast injury, it's a multifactorial in nature. It can be due to traumatic iritis, associated hyphema, or tear in the tubercular meshwork, or lens related vitreous hemorrhage, all these things. So initial stages we have to, especially closed globe injuries, we have to patiently give a conservative management to reduce intraocular pressure, and then we have to find out the cause, because angle recession per se in the immediate post-op, immediate following trauma, it will not produce a glaucoma. Usually, angle recession, they will produce hypertrophy, but it will take about minimum 90 days, 3 months to even 30 years. That's why Prem has mentioned lifelong follow-up is very, very important. Not only the area of angle recession, any angle recession, even if it is 90 degree, the patient can develop. So lifelong follow-up is very important. But you have to other hyphema and iritis. Most of the time it's simple iritis. We have seen just iritis will be there and patient will have about 40, 50. So in that case, in the treatment with the anti-glaucoma, with the cycloplegics and the steroids and etc. Suppose the hyphema depends upon the stage and everything. Lens related is a common cause, whether it's a subluxated or dislocated or traumatic intervention, depending upon the cause. Sometimes the patient may need strip surgery and sequential surgery so as to reduce the pressure. Then go for further, whether it's related to lens or something, then we have to go for lens removal or scleral fixation or trabeculotomy. So many things. So all is there is no clear cut or all is tailor made, custom made, depending upon the situation, depending upon the clinical features, depending upon the extent of involvement and the various causes for glaucoma, we have to tailor our treatment.
Thank you, sir. For want of time, we'll move on to the next topic.
Just one question.
Yeah. Yes, ma'am.
Yes.
Dr. Premanand, you said in the case where there was a subluxation and which is in the AC, you just did the vitrectomy alone and the patient regained 6/6 vision. Huh?
And the vision was even better. I mean, since the vision was retained, it was 6/6 to begin with, except for the vitreous in the antechamber. So we didn't do anything more. I mean, we just, since the vision was good, we did only anti-vitrectomy and the patient retained the 6/6 vision.
Okay.
There was no cataract.
No cataract.
No, I just want, is there a role for TPA in severe hyphemas?
It is there always. It's in the book. We don't have any experience. We don't have any experience.
Okay.
I don't know anybody having. But Dr. Rao?
We use it for retinal surgery.
No, sir.
Okay,
I'm not.
but not used. Yeah.
Not used.
There are so many things. Even Amicar has been used. Aminocapric acid has been used, and steroids, estrogen. So many agents have been used mainly to reduce the rebleed, and the TPA is to lyse the clot.
TPA is more of fibrin in the anterior chamber, Mohan. I don't think it works too much if you have a hyphema of the kind we are talking about.
Not less.
It is now making a resurgence in demix surgery because you can't unfold the graft if you have a lot of fibrin.
Okay.
Before you do that, you can do it, but not for hyphema like Sir said.
Okay.
Yes, Dr. Naresh, I invite Dr. Naresh to talk about the posterior segment involvements in firecracker injuries.
Thank you, RK sir. Thank you, madam. And thank you, Prabhu, for the invitation. And also would like to thank the esteemed panelists. Before I just go, I don't have any financial interest. And I would like to acknowledge Dr. Bhavani Adenuga, Piyush Kohli, and Deepak Kathar, and others whom I have not mentioned who have helped me in doing these works actually. So just as an introduction, the most common location of firecracker injuries are in the head and neck region. So for the obvious reasons, and the next is basically the hands. Being a specialized eye hospital, we don't come across the rest of the injuries. Mostly the people who are very sick, who have got the other injuries to the other part of the body, usually they don't come to us. Probably they'll be going to a multi-specialty hospital or a medical colleges. So most of the time we get the eye injuries. But the problem is the ocular injury due to firecracker cannot be managed by a single surgeon, whether it's anti-segment or porti-segment or an oculoplasty. Many times you need a teamwork actually, because there'll be a lid tear, associated corneal tear, then there'll be a foreign body. So a single person cannot manage. So in case of any severe injury, I think a team work is always mandatory. And we always say that firecracker trauma is one of the most preventable cause of ocular injury and the blindness. And this has been achieved by most of the countries where the legislation is imposed very strictly, unlike in India, which we'll be seeing later. So like the countries like Netherlands, where they use a lot of fireworks during their New Year's Day, after the legislation, their injury rate has come down close to 85%. And with more and more legislation, I think it is coming down. And with the implementation, the people are also more aware and they hold on to the law, which is very unlikely in our setup. So in 2018, actually, the Honorable Supreme Court has allowed us only the firecrackers for 2 hours, 1 hour in the morning and 1 hour in the evening. So in order to based on this, we have got the time slot of 6 to 7 a.m. and 7 to 8 p.m. in the morning as well as in the evening to fire the crackers. But however, this was not followed in our country many times because most of the people who are injured with this are outside this time slot and only 1/4 are within this time slot. So this is maybe because of the the failure of the administration to bring in sort of a implementing the law or maybe creating the awareness among the people. So basically in this presentation, I'll be just sharing a few of our publications related to the firecracker injury. And this one was published by us in the Nigerian Journal. And it was a hospital-based study published in 2018. And we collected the data of 2013 to 2015. And it was basically there was a window of 2 days before Diwali because that time there was no legislation, and 1 week after Diwali, and we could collect a total of 114 eyes of 110 patients. So I'll be basically omitting what are all the anti-segment findings which has been already discussed. So when we see Fortunately, almost 96% of these injuries to the eye are unilateral and only around 4% are bilateral. That is very heartening. But sometimes when the bilateral comes, it is usually very ghastly and it's very difficult to manage. And close to 81%, that is 4.2:1 is the ratio of the male to female in our series. And almost 55% of the people are less than 15 years of age. And fortunately, 87% are closed lobe injury. The reason I'm saying fortunately is most of the open lobe injury will end up in thysis bulbi or endophthalmitis or other related, and they'll not be having better vision at the end of the procedures. But in closed lobe injury, they may not be having good vision, but at least there will be anatomically some good eye in them. So this is what actually I am omitting the anti-segment finding. Especially in the anti-segment, almost 42% of the patients who reported to us had hyphema. But when it comes to the question of the posterior segment injury, in case of closed lobe injury, 31% had vitreous hemorrhage, and choroidal rupture was seen in 16. And most of these choroidal rupture are indirect choroidal rupture. Very rarely we come across direct choroidal rupture in case of firecracker injury. And if that choroidal rupture is involving the fovea, then it is bad. And we have seen CNVM developing over a period of time in these cases. And we had a few cases of subretinal hemorrhage, choroidal detachment, and commotion retinae in these cases. And retinal tear was also found. And whenever there is a retinal tear or dialysis, usually they lead to retinal detachment later on. In case of open globe injury, which is just the 13%, most commonly it is the foreign body which we have seen. But unlike the foreign body, which we seen in case of hammer and chisel, where usually it is the metallic piece from the chisel which will be entering, and usually because of the the high temperature nature, many of the time there will not be endophthalmitis, and it is a single foreign body, easy to visualize before the hemorrhage happens, and removal is also easy. But unlike that, in case of firecracker injury, the foreign bodies are buried. We have removed right from the stapler pin, and most commonly what we see are two things. One is the paper which is covering the so-called bombs. The other one is usually these bombs are sealed with some clay in the bottom. These are the two things which usually enter the eye, and they are very difficult to remove. And also the corneal injury or the scleral injury caused by these foreign bodies are very, ragged. Actually, it's very difficult to suture. So unlike the foreign body due to chiseling, this is not that easy to remove the foreign body in these cases. But if it is an isolated vitreous hemorrhage, which we have seen in 14% of the cases, it's very easy to remove. Subretinal, the hemorrhages are usually, if there are no tears, we go for gas injection, make the patient to maintain a prone position so that the gas is dispersed away from the fovea. Yes, in case if it is very heavy, you can go for the TPA injection and then gas injection. And we have come across ruptured globe in 7% of the cases. There are 1 or 2 cases where we have sutured and we could retain the vision, but most of the time it is not possible. When you take actually the visual outcome at presentation and at the end depends on the initial vision. If the initial vision is poor, usually the outcome is very bad, and close to 20% of our cases had very poor vision at the end of their treatment schedule. And the same thing with the closed globe injury also. Only 43% retained a better vision of 6/18, and most of the cases had less than 6/60 or less at the end of the complete procedure. When we followed up these cases for a long term, so these are the posterior segment complications as well as the anti-segment which we came across. There was macular or foveal atrophy that may be because of the commercial retina which has happened. We had a case of CNVM which has developed through the choroidal rupture which has happened during the time of the injury, and there was a glaucoma in 6% of cases. Thysis bulbi was in 2 in case of closed globe, and 7% in case of open globe injury. And usually the open globe injury had a high rate of retinal detachment which has been removed. And we usually have the macular hole in closed globe injury. The closed globe injury macular holes are not immediately treated. We can wait up to 2 to 4 months because spontaneous closure of these holes are there in almost 40% of the cases. Only if they're not closing spontaneously, then we'll go in for the repair of the macular hole. Endophthalmitis is quite common in case of open globe injury, and usually Bacillus cereus organism, and the outcome is mostly not favorable in these cases. So this is one of the cases where we have removed the stapler pin which is entered inside the eye while bursting the cracker. Probably the child might have covered the cracker with some cracker boxes from which the stapler might have been, and this is a case of a foveal atrophy. And in all these cases, out of 114, we have performed surgical procedures in close to 55% of the, 55 cases. That is in almost 9 eyes, more than one procedure was required, especially in open globe injury. First, we'll go for the tear. The basic idea is to maintain the integrity of the eyeball. Once the integrity of the eyeball is maintained, then we'll go for the repair of the retinal detachment, or if there is a vitreous hemorrhage. So it is very difficult, and it is the counseling is very, very required, because the most important question at the end of counseling, the patient asks is, where a problem or no? This is a very common question we come across. So counseling, not only to the patient, to the entire family, is always mandatory, and explaining the actual situation is important. And in case whether it is open globe or closed globe, it doesn't matter. Go in for a X-ray PA, orbit PA view, because X-ray is a mandatory thing for medical legal procedures. In case if it is not done, then it will be in soup. Then we can go for CT scan for the exact localization of the foreign body. If you are ruling out metallic foreign body, then you can go for MRI to locate the non-metallic foreign bodies. So as I was telling, we wanted to know whether our people are actually following. So this was the one which was published by us in 2021, based on our 2019 data. Fortunately, 2020 and 2021, the legislation was taken care of by the corona, not by the government. So we didn't have many cases. And this year there is no corona. Probably, I think the legislation has to take care. So we might be doing, we have formed a force actually to find what our cases are. So this was published by us in IJCM in 2021. So the same thing, actually 1 day prior and 5 days post Diwali, we have taken the data in 2018, and we have got close to 93 patients. And as similar to the earlier data, almost 80% are males. And unfortunately, in this case, the bilaterality has increased from 4% to 20% close to. And the median age was 13 years, and the age ranged from somewhere from 7 years to 74 years in the study. And when we see, actually close to 63.4% are from urban background. So education has not made any change in our people, and only 36% are from the rural background. And when we inquired, actually almost 67% were playing near the homes. So among those less than 18-year-old, only 30.9% or 31% were bursting crackers under supervision, and the rest were not doing. The reason why I am saying this is usually the children are very inquisitive, and they don't have any fear, and they don't anticipate any danger in this. So that is the reason, one of the reasons why most of these injuries are very common in children. And as I was telling regarding the, following the legislation of the country, when we saw that only 25.8% are injured during the allotted time, the rest 74 or 75% were injured outside the allotted time. That means like the crackers were burst outside the allotted time. So nobody is aware of the legislation, or nobody wants to follow the legislation. And we inquired, most of the defaulters say that they were unaware of the new legislation. So these are the among the defaulters, only 52% were supervised, and among the unsupervised patient, almost 84% had an injury to this. And among them, 12.9, as I have told, had an open globe injury, and almost all the open globe injury went in for surgery, and 50% had severe trauma and thereby lost vision completely. And that is close to 10% of 93% cases, 93 cases, almost 9% of 9 people have lost the vision completely. So the another interesting case, so we have already discussed the posterior segment finding, and Dr. Premanand was talking about the cyclodialysis, which is happening following trauma. It is not the, glaucoma which always happens, but sometimes you can have the low IOP also. This patient was a 27-year-old male who sustained bilateral ocular injury following firecracker injury, and his vision was counting fingers in both the eyes, and his IOP was very low. And these are the anterior segment finding. But over a period of time, his vision improved to 618 and 624, but the IOP remained at 4 millimeters, and the patient had hypertonic maculopathy in both the eyes. And we can see when we are doing this UBM, there was a cyclodialysis. And for want of time, I am skipping the surgical part of it. So in this case, what we did is we went in for cyclodialysis repair, which is done by raising two flaps and suturing the ciliary body to the sclera. And we have injected the silicone oil also after 5,000 centistrokes after doing a vitrectomy. And at the post-op, the BCVA improved to 612 in both eyes, and the IOP stabilized within normal limit. And at the end of 6th-month follow-up, we removed the silicone oil in these cases. So it's as I was telling, it's not only the a single surgeon who can be managing this. It is basically a teamwork which will have to manage these injuries. So the main goal in this case was to close the cleft and to restore the opposition of ciliary body to the sclera, which was done by us by suturing it, to increase the IOP and to improve the visual acuity, and to prevent further complication, which was achieved by doing the surgical procedure. And we have injected silicone oil basically to prevent the inflammatory mediators from reaching the ciliary body, which can adversely affect the aqueous production, and also to approximate the detached ciliary body to the scleral spine. So with this, actually, we'll conclude with a few of these things. So how to, prevent this related injury? Most of the time, actually, as I have told, by imposing the law strictly, they have reduced the ocular injury to close to 87%. But however, it has not happened in our country. The other thing is we have to have a continuous, the awareness creation program to the children, both the school as well as the college, so that it is continuous and not on a single day or just before Diwali. And many times by using this, the polycarbonate glasses along with the fireworks when they are sold, which is happening in the country like Norway, which has decreased the chances of ocular injury. And we can, this was from Singapore, where they emphasize on distributing the pamphlets, which emphasizes on using the protective wear, as well as the safe handling of the fireworks, as well as the first aid measurements to be taken. So if these things are implemented, I think to some extent we can not only the anti-segment, the posterior segment, most of these the firework injuries can be avoided. These are the pamphlets which are produced. And with that, I would like to thank the organizing team and the TNOA for giving me this opportunity. And thank you once again. Have a safe Diwali.
Thank you, Dr. Naresh. As you pointed out, it's very important that these injuries need multiple specialty people to handle most of the time, and that's why we also call many specialty people to talk about different aspects of these injuries. And for want of time, we'll go on to Dr. Namrata's talk about what AAOs or our governing bodies have done so far to prevent this kind of injuries.
Yes, Manjula, you can. Yeah.
Yes, Dr. Vilshar.
Yeah.
I don't know whether you can hear. Already firecrackers started here outside. Manjula, we can't hear.
Manjula, there is no audio.
One second, doctor.
Okay, no, yeah.
No. Still, the audio is not there.
Manjula madam, if it's an iOS device, your audio won't come out that properly.
Yes,
Always
doctor.
some audio issues with iOS.
One second, doctor. Stop share and start step.
Okay. Yeah.
Good evening, ladies and gentlemen. At the outset, I would like to thank Tamil Nadu Ophthalmic Association for making me a part of this wonderful webinar, which is titled Firecracker Injuries, Fallacy in Festivity. And I would like to thank Dr. R.K. sir for making me a part of this. And I would be talking to you about prevention, advocacy, and the role of All India Ophthalmological Society. Now, if you look at the fireworks, they injure thousands and cause thousands of burns and thousands of fires. And if we look at this cartoon, it very clearly shows that almost 1/3 of the burns, they involve the upper part of the body, which includes the eyes, the head, the face, and the ears. It is important to prevent the firecracker injury, and to avoid any accident with fire, it is recommended to wear cotton clothes and stay away from the synthetic material. Then one must also look at the quality of the crackers, because one must purchase these firecrackers from legal manufacturers and ensure to go through the instructions before actually bursting them. And good quality firecrackers can reduce the risk of a dangerous mishap. It is important to instruct children when they are using the firecrackers and to educate them about the appropriate way to do so. It is also important to supervise them while they are playing with the crackers. And we should have a fire extinguisher in close proximity to the area where you are bursting the crackers. And this is very essential. And even a bucket of water, sand would be useful to tackle an unexpected fire. Then it is critical to note that one must never burst firecrackers in a closed area. A first aid kit should always be handy while you or your kids are enjoying the fireworks. And it is important to dispose of the used firecrackers immediately and carefully. So either a bucket full of water or sand can be used to douse them off and to put out its heat. It is important to prevent any mishap that can occur. Now, if the firecracker does not go off immediately after the ignition is completed, then this is what is recommended. That is, everybody should walk away to a safe distance, no less than 3 meters, count up to 60. And then somebody without the flammable clothing should approach with a bucket of water and completely soak the firecracker. And again, wait for some time and dispose of the defective firecracker and contact the authorities for reporting. It is, I think, the duty of the ophthalmologists to generate public awareness about the firecrackers and the problems that they can cause with the eyes. And so one can do TV talk shows or radio talk shows to make the public aware about this. Then, of course, nowadays, even Facebook or Twitter are good options for public awareness. And this is what I wanted to highlight, that All India Ophthalmological Society has signed a memorandum of understanding with the Ocular Trauma Society of India, as well as with the International Globe and Adnexal Trauma Epidemiologically Study, that is the IGATES, in conjunction with the National Human Rights Commission, that is NHRC. And a document has been released to prevent, minimize, and mitigate the ocular trauma. And this is one positive step which has been taken by the government. All these stakeholders which are involved in the trauma, whether it is the NHRC, that is the National Human Rights Commission, or the Ocular Trauma Society of India, or the various ministries, which included the Ministry of Industry, the Ministry of Chemicals and Fertilizers. All of them met in a meeting which was organized in the NHRC office. And we came out with a document which was released by the NHRC very shortly on 11th October 2022, which has given advisory to prevent, minimize, and mitigate ocular trauma. So this is the part of the document that I am showing you. And these are extremely useful, not only for preventing the firecracker injuries, but any kind of ocular trauma. And it gives advisory to the various industries as well, that certain chemicals or certain packaging should be changed, and people should be made aware about the fact that they could be harmful. So this is the entire document which talks about the development of integrated ophthalmic trauma units, as well as rehabilitation of the victims of the ocular trauma. And this is how the data should be reported if there is any ocular trauma which happens. Now, essentially, if we look at from the burns point of view, it says that Ocular Trauma Society of India and AIOS will work very closely together to analyze the data, generate the data, and assess the data and the statistics, and will also submit this data to the NHRC so that appropriate policy decisions can be taken. Essentially, it says that one has to create public awareness on major causes of ocular trauma, which includes the firecrackers, launch publicity campaign in the form of print, electronic, and social media, installation of posters and hoardings at hospitals, dispensaries, schools, colleges, industries, establishments prone to ocular trauma and other prominent places, inclusion of a chapter on ocular trauma in curriculum of schools, and especially how to prevent injuries from occurring, as well as in the industrial training institutes. Mandatory printing of warning on items having potential to cause the ocular trauma, which includes the crackers. Regular organization of seminars, workshops, and meetings on ocular trauma for high-risk persons such as lathe and other machine tool operators, welders, carpenters, persons handling hazardous chemicals, farmers involved in spray and handling of insecticides, pesticides, etc. Then apart from this, there should be also observation of the Trauma Awareness Week or fortnight once in a year that can happen at the time or just prior to Diwali, so that people, they take proper precautions before Diwali and Dussehra. Creating of eye injury awareness videos and disseminating these videos through news channel or TV network. Identifying the firecrackers which have potential to cause eye trauma and imposing a ban on such use of these crackers in public places by children less than 12 years, except under direct supervision of an adult in closed spaces and large public gatherings, and imposing a ban on sale of bows and arrows, pellet guns, and toys having sharp edges, and such other toys having potential to cause eye injuries to children less than 12 years. So I think as AIOS members or as ophthalmologists, our duty is to bring about awareness. Because when an ophthalmologist says so, then people would listen. And also we should curate relevant content and medium of a campaign to attract the current biggest population, which are the millennials. Now, millennials are technology native people, therefore old-fashioned health awareness campaign may not help. And health campaign messages on digital platform do spread faster and able to be shared vastly, speedily, retrieval and environmentally friendly also. So burn awareness campaign should be done on a digital platform, and I think this is a doable thing and it is a wise approach. So 7 steps to celebrate safe Deepavali are that you should wear cotton clothes, ignite crackers away from vehicles, keep first aid handy, pets hate flashes, so keep them indoors, handle fireworks with caution, store your fireworks safely, and of course instruction to children, which is most important. Wish everyone a very happy Deepavali, and please celebrate an environmentally safe Deepavali. Thank you for your kind attention.
Thank you, Dr. Namrata. And I think with this, we have come to the end of the presentations. And I would like panel and Dr. Ramakrishnan to give an overview of the program and any other questions about the last two topics also. Sriram, would you like to say anything about Naresh posterior segment?
Yeah.
Unmute. Sriram, you have to unmute.
Unmute. Yeah.
Sorry, ma'am. Sorry.
Yeah.
No,
Yeah,
Naresh,
yeah, yeah,
Naresh
yeah.
has covered the topic in very well, very. This thing about this 1 hour restriction and more than most of the injuries happening outside that time. That's because that if the time is small, then there will always be more people outside that time only. If the time is large enough, then you'll find if there was no restriction or a very short period of restriction, you will find more people outside the restriction. So that is more of a, what shall I say, observational bias. Because the time given is short, you'll always find less people inside that period of time only. And we are not a country who follows rules that much also. So it's pretty obvious.
Yeah, I think more constructive ways, maybe like as Naresh pointed out, targeting the school children with awareness thing directly, and also if in future it can be completely that domestic use of these firecrackers, it can be completely banned, and if it is more regularized as a commercial and properly guided one, and then it will be of more use. And also selling this eye protective glasses along with the firecrackers and instructions. These things also might be helpful in future.
Yes, ma'am, like Dr. Namrata madam pointed out in her talk, she spoke about having particular quality in firecrackers. I think we should stop the production or reduce the production or regulate the production first. After it is produced and comes out into the market, it is very difficult to regulate consumption. So it is the production which needs to be regulated and curtailed first. I think that is where the government should start looking at. Using everything and then it out.
Sriram, we are injecting sweet lime into the intravenous route instead of plasma in this country. Actually, you can refer 2 days ago. That is the state of this country.
Naresh, if you go on to Twitter, sorry to digress, if you go on to Twitter, that is actually a fresh frozen plasma packet, which the patient saw. He thought blood only should be red. And it was that pale yellow color, so he thought it was Mosambi juice. It is a patient's version. It was not Mosambi juice.
But why the patient died? Okay.
The patient died because of transfusion-related problems. Yes, but he was not injected Mosambi juice. The attendant looked at fresh frozen plasma and thought, if it's blood, then blood product, why isn't it red? Why is it pale yellow?
He said it's Mosambi.
So then that's how rumors spread also in this country.
Definitely, the cough syrup is not a rumor.
Yeah, cough syrup is true. That's what I'm saying. See, again, cough syrup problem, you have to regulate the production. You cannot ask people now to buy good cough syrups and drink. You have to regulate the production. So you have to start at the root. The root is at the production and not the consumption.
Dr. Revati, I think that Dr. Namrata's suggestion that in school books they have to have a lesson on ocular injuries, that will be very good.
Yes.
Yeah.
Yes, ma'am.
Yes,
Yes.
that's good. Yeah.
Yes.
Yes.
Sir, I just have two suggestions, sir. One is, I think Namrata's talk has opened the eyes for all of us. Just like this eye donation awareness, what she has suggested, for 2 weeks between August 25th and September 8th, we create a lot of awareness among the people, among the general people about the eye donation. That has actually had a significant impact, I would say. A lot of programs are occurring. Similarly, before the Diwali, okay, I think the AOS can do something like that, and 2 weeks dedicated only for the ophthalmic trauma. So from ocular trauma, the terminology, even the American thing of has accepted now as ophthalmic trauma, because ocular trauma means only the eye. Ophthalmic trauma means includes the adnexa also. So it has become ophthalmic trauma now. So I think that is important for all of us to have 2 weeks, and so that we can create awareness among the public. Because only by awareness we can prevent this problem. I think there is a very huge thing. Second thing is, as Sriram was suggesting, because about 15 years back, I went to Sivagasi and I was inspecting all the factories just to find out what is the quality of crackers there. Absolutely no quality control at all. Even today, I'm telling
Yeah,
you.
yeah, correct.
There is no quality control at all. Okay, if you don't have any quality control and putting that in the public at the endangering of the lives and the eyes of so many people, I think it is something. It's like a criminal murder. So that's what I would say. So it's quality control. It's very, very important. All of us have to think. Now, bigger bodies like AOS can insist on that. So smaller bodies cannot do it, but bigger bodies, because we have big strength, we have bigger say doing, and the AOS, the panel, what Nirmal Frederick was talking about, the discussion what they had about a month back in Delhi. I think that is paved the way forward, because only if you have bigger lobby to support this thing, and consistently we have to keep on talking about this. Otherwise, it will not work. We need we'll just have webinars like this, and same problem will occur. Tomorrow we will see a lot of patients with cracker injuries. But we need to have a consistent lobby which is advocating this on a sustained format, I would say. That is my message I want to give, my 2 cents.
Maybe a government-aided advertisement in the TV channels, as all governments have their own TV channels. During the Diwali day, I mean, in between every program, you can put an ad for about 15 seconds, which tells you how to protect yourself from injuries and all those things. That will do a lot of benefit and will reach a lot of millions of people, rather than doing other things. If the government can do it.
Anything, Revati?
Yes, sir. I think we can wind up with this.
Lovely webinar, Revati. Very useful.
Announcement to Tamil Nadu Ophthalmic Association and Indian Medical Association Tamil Nadu State Branch jointly organizing a webinar in commemoration with the World Sight Day. That's on 30th September, Monday. The topic is Love Your Eyes. We have a wonderful topic, pediatric eye disease for physician and systemic disease and eye. It's a very one of the important topics. So many people across all the specialties will participate in the panel discussion. It's by 10 o'clock in the morning. We will send you the flyer soon, and all of you better tell your friends and other things so that we can make it a big one. Yeah.
I would like to thank all the speakers for their time for the social cause, and I would also like to thank all the panelists for their excellent opinions. And thank you, sir.
Siddha.
Formal vote of thanks. I think he's already given a short vote of thanks. So thanks to our dear President, Dr. R.K. sir, who has taken the initiative to conduct this on the eve of Diwali to make everybody aware. Thanks to our past President, Dr. Mohan Rajan, for spending his time here, and our President-elect, Dr. Nirmal Frederick, and our Vice President, Dr. Arulmozhi Varman. Big thanks to all the 4 panelists, respected Dr. Srinivas K. Rao, Dr. J.K. Reddy, and Vasantha Madam, and my dear friend Thiru. And big thanks to Revati Madam for putting it all this together and then taking this through in a very, very smooth and concise and precise way. Thank you so much, Madam. And thanks to Prabhu Vijayaraghavan as well for helping Madam and coordinating the whole show. Thanks to our ARC Chairman, Dr. Atiq Sheikh, and the speakers, Dr. Anita Venugopal, Srinivas Rao sir, Dr. Maneksha, Dr. Premanand, Dr. Naresh Babu, and even though she couldn't be here, Dr. Namrata Sharma Madam, who made it a point to make a video of her speech and send it to us. She is right now in Colombo. And I spoke to her this morning and she said, I'm not going to be there, but I've sent a video and the video should be played. So thanks to her as well. A big thanks to all the support team and especially people at Numerotech and the sponsors for this meeting, Orolab, Mrs. Orolab. A big thanks to one and all, and for all the delegates who came in large numbers and attended this webinar. Thank you. And hopefully we meet again in the webinar for the World Sight Day on 30th of November, as Dr. R.K. sir detailed. Thank you so much.
Thank you. Thank you all.
Thank you. Thank you. And happy
Thank you all.
Diwali.
Very happy.
Happy
and safe
Diwali.
Thank you.
Happy and safe Diwali.
Thank you. Thank you.
Thank you.
Thank you.